I would like to introduce Dr. Victor Santiago. He is currently a fourth-year resident here at our APCP program. He originally hails from Puerto Rico and got his medical doctoral degree from, bear with me, Universidad Autónoma de Guadalajara in Guadalajara, Mexico. And during his time here, he has visited and presented at USCAP a couple times and published a couple papers. Beyond that, been a stellar chief this past year and a good friend. So, I'd like to introduce Dr. Victor Santiago.
Well, can everyone hear me okay over there? Okay. Well, thank you for the introduction, Regina, and welcome to my grand rounds, everyone. Are hematogones the heroes or villains after transplant? I have no disclosures for this talk. The objectives for my talk today are, first, to describe the basic biological characteristic and immunophenotype of hematogones. Secondly, we're going to discuss hematogones and their association with prognosis. And lastly, we're going to discuss hematogones in the setting of autologous stem cell transplant. Here's a little outline of how the talk is going to go today. The first part of the talk will deal with what are hematogones, who are they, what are they, where do they come from, when do they appear, and why. The second part of the talk will focus on hematogones and their prognosis. And the last part will focus on the study I was part of, where we looked at hematogones following autologous stem cell transplant in diffuse large B-cell lymphoma patients and plasma cell myeloma patients. So let's go ahead and start with the first part. Hematogones, who are they, what are they, where do they come from, when do they appear, and why? So for those of you who don't know what hematogones are basically by definition are B lymphocyte precursors. They have a morphologic and immunophenotypic overlap with neoplastic lymphoblasts. For several decades, they didn't know what they were, what these cells were, and there are many names in literature showing that they can be called marrow precursor cells, post-therapeutic stem cells, lymphocytes, blasts, and even some people call them common ALL antigen positive cells. These hematogones were first described as lymphoid appearing cells in bone marrow of aspirates from children. The term hematogones come from the word hematogonia, which is a Latin word meaning blood maker. And for several decades, they didn't know what these cells were. They were discovered in 1937 by an individual called Vogel and a second individual called Erf. They described these cells in bone marrow from children. Then in the 1960s and 1970s, people started to notice marrow lymphocytosis in patients treated for ALL, and they didn't know if these cells were relapse or if there were recovery of the marrow after treatment. It wasn't until the 1980s that immunohistochemistry and immunofluorescence caught these cells and put the definition that they were precursor B cells. Then in the 1990s, flow cytometry differentiated these cells from neoplastic lymphoblasts. So in terms of morphology, we're going to see later that there is a spectrum of different stages of maturation for the hematogones. When they start in stage 1, which is this picture over here, they look, as you can see here, they have a high NC ratio, kind of immature chromatin, looking basically overlapping with the morphology of a lymphoblast. So, but since they have this spectrum, as they mature, their morphology changes. And in the picture on the right side, you can see that this is a more mature cell, kind of smaller, with a more mature nuclear features. So in morphology, there is a big spectrum for these hematogones. This picture over here is showing you to contrast between hematogones and lymphoblasts, and I'm going to tell you that picture A, they represent hematogones, and picture B represent lymphoblasts, B lymphoblasts. So you can see that there is the morphology is pretty similar, and there is no way you can tell in morphology which cell is which. So flow cytometry came into the rescue to identify these cells, and you can probably recognize some names in these papers, but Dr. McKenna published in 2001 this study, and in 2004 this study describing the immunophenotype of hematogones. Then in 2004, he compared the morphology of hematogones with neoplastic lymphoblasts. So what is flow cytometry? For those of you who don't know what flow cytometry is, probably everyone here knows, but it's an immunophenotyping technique in which a suspension of cells are stained with a specific fluorescently labeled antibody and then analyzed by the flow cytometer. The flow cytometry involves a lot of physics in it. It includes the fluidics, optics, and the electronics. And here's just showing you a picture of how the flow cytometer works. Here, the top part is the fluidic part. The cells are aligned as a single line cell system to be analyzed by the flow cytometer. A laser light source will hit those cells and record a specific characteristic for the cell, either the antibody or physical characteristics such as the complexity of the cell, the size of the cell, etc. So let's look at the immunophenotype of hematogones. So this is for those of you who rotate through flow cytometry or in the heme service. This is probably high yield here. It's pretty good if you pay attention to it. But basically, hematogones, there's different stages, and they stain differently as they mature, basically. So here, in this side, we have the most immature hematogones, stage 1 hematogones. They usually stain with markers like TDT and CD34. Those are, as we all know, immature markers. They also express CD10, which is going to be bright at the beginning, and they also express CD19, which is going to be dim or weak at the beginning. At this stage, stage 1, they also express CD38 pretty brightly. Then, as they mature in their process, then they will lose those immature markers. They will lose the TDT, they will lose the CD34, they will still stain with CD10, they will stain with CD19, but the CD19 is going to start to get stronger as they mature. CD22 is going to be there, and CD38 is also going to be there bright. Then they keep maturing at stage 3 or even as mature B lymphocytes. Then they start to gain CD20 and surface light chain. Now when they become mature B cells, they will lose the CD10, keep the CD19, and then keep CD20 and express light chains as they become mature B cells. So that's how basically the different stages of hematogones will stain by flow cytometry. Here's another picture showing you the same maturation pattern. Again, in stage 1, they will stain with immature markers. They will stain with CD10. The CD19 will be dim in stage 1. Here, the CD45 wasn't in the previous picture, but early hematogones will be dim for CD45, and they will gain stronger CD45 as they become mature B cells. And again, as they become mature B cells, they will have CD20, and they will gain light chains as they mature. So that's the specific pattern for the hematogones. Now, let's look at some flow plots so we can put this into pictures. So here, this is from Dr. McKenna's paper, the one in 2001. And here you can see the first plot over here is the forward scatter versus side scatters plot. The forward scatter will tell us how big are the cells. So larger cells will be over this side. The side scatter will tell us about the complexity of the cell, how complex is that cytoplasm. Usually granulocytes fall over this side with a high side scatter. So the hematogones are labeled here as color purple and green. The blue population is mature B cells. As you can see, the hematogones fall. They're not too large, they're not too small, so they're kind of in the middle there. So this next plot, CD20 versus CD10, I want you to pay attention to the shape of this plot because it's going to tell us something later. But pay attention to the shape of this plot. But anyway, the purple population are the early hematogones. They express the CD10 pretty strong. Then as they mature, this is the intermediate to late stage hematogones. They start to lose the CD10, and as they become mature B cells, they will lose the CD10 and keep the CD20 as mature B cells. So that's how the CD20 versus CD10 plot looks like. Next here we have the CD34 plot versus CD22. As I said before, the early hematogones will be 34 positive. As they mature, they will lose the CD34 over here and become mature B cells. That's the dark blue population. Lastly, this last plot over here is CD34 versus CD20. You can see that the early hematogones, immature stage 1 hematogones, are 34 positive, and as they mature, they lose the CD34 and they gain very bright CD20 to become mature B cells. So that's some plots showing you how hematogones, the spectral maturation of hematogones. Here's just another example of hematogones. The hematogones in this plot are the yellow population. And again, they're not too large, they're not too small, kind of the same area in the forward scatter. They have the CD10, this is CD10 versus CD22. They have the CD10 over here. This is CD34 versus CD20, and you can see here the early hematogones are CD34 positive. As they mature, they lose the CD34 and gain CD20 to become mature B cells. And again, this is the plot that I want you to pay attention to the shape. They're expressing CD10. These are the intermediate early hematogones, late hematogones over here. They lose the 10 and then they become mature B cells, which is the dark population. And then here we have CD38 bright, which are the hematogones over here. Lastly, one more example. Here we can see, again, they use different colors for different stages. The dark green are the early hematogones. The light green are the intermediate hematogones. And the more light green are the later hematogones. And then the mature B cells are the blue population. And as you can see, as they mature, they gain CD45 strongly. The 19 again is more strongly as they mature. And again, here's the CD20 versus CD10 plot, which I want you to pay attention again to the shape. Early hematogones will be bright 10, then they will start to lose some of that 10, and as they become mature B cells, they will be negative for 10 and bright positive for 20. So that's another example. So remember that I've been saying, just look at the shape of the CD20 versus CD10 plot. So you can see it's kind of repetitive. We have this of what people call, of what I think it's a bent extremity, lower extremity. So this is probably the thigh, this is the leg, and then this is the foot over here. And that's the specific pattern that we see in this plot over here. So again, if you don't get anything else from my talk today, this is probably the most important. So if you're in the flow lab, it's good to be able to recognize this pattern. So again, the lower extremity that is bent, those are the hematogones on the CD20 versus CD10 plot. So this is just to show you how B lymphoblasts look like on flow cytometry compared to the hematogones. And here the B lymphoblasts are the dark red population, and then the hematogones are the yellow population. And as you can see here, the lymphoblasts are larger by forward scatter when compared to the hematogones, which are the yellow here. They have overexpression of the CD10 in comparison to the hematogones that are in yellow. They have overexpression of 34 over here. And then in the CD34 versus CD20, you can see that these lymphoblasts are positive for 34 and 20 for both. So that doesn't happen with hematogones, right? And then the 38 is underexpressed on the lymphoblasts, but not on the hematogones, which is going to be overexpressed. So just to compare with what a lymphoblast population looks like. So some facts on hematogones. They're usually located in bone marrow and blood. They have been reported in tonsils and lymph nodes of fetuses and children. There have been reports showing that bone marrow of premature neonates can have up to 25% of of hematogones in their cellularity, and they decrease by age. And that statement of decrease by age has been proven by multiple studies. Here is a graph from, again, Dr. McKenna's study. And as you can see here, in the y-axis, we have the percentage of hematogones, and in the x-axis, we have the age. And we can see here that there is a significant decrease in the percentage of hematogones with increased age, as shown by this regression line over here. This is also from Dr. McKenna's study. And in this particular graph, we have patients with 5% or more hematogones by age group. Here we have on the y-axis the percentage of cases. In the x-axis, we have the ages. And again, you can see a direct decline in the proportion of patients with more than 5% hematogones with increased age. So again, proving the point that they decrease by age. Lastly, this is also from Dr. McKenna. And as you can see, again, y-axis percentage of hematogones, x-axis the age, and there is a significant decrease in hematogone percentage with increasing age, as shown by this picture. In terms of diseases and frequency, hematogones have been shown to be increased in conditions like lymphomas, after chemotherapy, in HIV/AIDS, in toxic bone marrow damage, viral infections like CMV, in ITP, reactive lymphocytosis, copper deficiency, Gaucher, and red cell aplasia. Studies have shown also that there is decreased hematogones in conditions like MDS, aplastic anemia, and CML. And here's just a last graph showing you, this is from Dr. McKenna's study, also from 2001, showing you the spectrum of conditions where they saw increase or 5% or more hematogones in all these different conditions. And the highlight numbers here, so they saw a lot of hematogones in patients with non-Hodgkin lymphoma, for example. Here, post-chemotherapy, they saw patients with a lot of hematogones. Also in cytopenias, they also saw a lot of hematogones. So let's move on to the second part of my talk. Here, I'm just going to show you a couple of studies that talk about hematogones. Now that we know what they are, a couple of studies showing what hematogones have to do with prognosis. So here's a study from 2012. Maybe you recognize some of the names here too. So in this particular study, they look at patients with AML after umbilical cord transplant. They had 88 patients. They analyzed hematogones in bone marrow aspirates. In this particular study, they didn't use flow cytometry. They used morphology. And at day 21 and at day 11. I have to tell you that for their analysis, they used a 0.9% cutoff as the presence of hematogones or increased hematogones to make their prognosis analysis. And so what they found in this particular study is that at day 100, patients with greater than or equal to 0.9 hematogones had a better survival than patients with less than 0.9% hematogones. They also found that patients that had, this was at day 100, patients that had greater than or equal to 0.92% hematogones have less treatment-related mortality than patients that had less than 0.9. So they used that 0.9 as their cutoff for increased hematogones in this particular study. Here is a second study. This one is from Japan, from 2013. And in this particular study, they have 108 patients who received allogeneic stem cell transplant. They have different conditions that they put in this study, including AML, MDS, ALL, and non-Hodgkin lymphoma. They look at hematogones by flow cytometry in this study at day 25 and at day 32. And I have to say that they used a cutoff of 5% hematogones to say that they were increased in this study. And what they found is that patients with more than 5% hematogones in the bone marrow had a significant prolonged overall survival when compared to patients that had less than 5% hematogones. And it was irrespective of the disease. Like it was seen to all the diseases that they study in this particular study. Lastly, This last study from 2015, again from Japan. They had 192 patients after allogeneic stem cell transplant. They had patients with AML, MDS, ALL, aplastic anemia, non-Hodgkin lymphoma, and adult T-cell leukemia. They look at hematogones by flow cytometry in this study at day 30, and I have to tell you that their cutoff for the presence or increase of hematogones was 0.25. So that was their setup or cutoff for the presence of hematogones. And what they found in this study, that patients that had that 0.25 cutoff or more had a better overall survival than patients that didn't have that 0.25 cutoff, and it was significant over here. So it seems like through all these past studies, having a lot of hematogones had a better prognosis for these patients. So now into the last part of the talk, and this is probably the longer part of it. This is the study I was part of. As we all know, this is a very busy transplant center, and we were noticing a lot of patients with very large numbers of hematogones in their bone marrows in the flow service. So we decided to investigate this further. So we did the study to better quantify and see the frequency and magnitude of these strikingly high hematogone percentages in our patients and attempt to identify any associated factors with this increase in this type of cells. So we did a retrospective study with adult patients that underwent autologous transplant for diffuse large B-cell lymphoma and plasma cell myeloma. And just as a reminder, diffuse large B-cell lymphoma is a neoplasm of large B cells. These patients are usually treated with R-CHOP at the beginning, and if they relapse, then they undergo autologous transplant. On contrast, plasma cell myeloma patients, they usually don't get that heavy chemotherapy at the beginning. They go straight to transplant. And plasma cell myeloma is a plasma cell clonal process. So our cohort included patients, again, that underwent autologous stem cell transplant for diffuse large B-cell lymphoma and plasma cell myeloma from the years 2004 to 2015. And to be part of the study, each patient needed at least one post-transplant bone marrow flow cytometry study to be part of it. Here's just a table showing you the different treatments for the two groups. Basically, the DLBCL patients got a more heavy conditioning regimen before transplant when compared to the plasma cell myeloma. I just wanted to highlight that over there. So we look at the electronic and medical records to extract clinical information such as age, gender, medical history, staging, and follow-up. The disease status and course after transplant was taken from summary of clinical notes, and flow cytometry information was taken immediately in the immediate pre-transplant marrow and then in all the subsequent post-transplant marrow for each patient. So the flow cytometry process was performed in all patients in bone marrow aspirate samples with the routine protocols in place at that time. We use A-color analysis on the FACS Canto2. That's the flow cytometer that we have here. And the flow data was analyzed in the Calusa software by me and or Dr. Corbell. So here's how we analyze the hematogones for the two different sides of the patients. And so in the flow lab, we have different tubes or different assay, different panels for the different neoplasms. So there is like a plasma cell tube, plasma cell assay. There is like a B cell tube, a T cell tube. So basically, in each of the panel, we have A markers over here. And for the diffuse large B-cell lymphoma patients, these are the markers that are in the tube for the B cell neoplasms. And this is the markers. These are the markers that are in the plasma cell myeloma assay or tube. I have to tell you also that in 34 of the 631 flow studies, that's 5%. And hematogone percentage was obtained by both of the methods, and they were all plasma cell myeloma patients. I also have to tell you that in 81 of the 631 flow studies, that's 13%, the data was performed by four-color analysis, and it was extracted from pathology reports. So this is just an example of how the hematogones look for the lymphoma patients with that panel that I show in the table. And we caught the hematogones when they were staining with CD19, staining also with CD10, with no expression of light chains over here. No to minimal expression of light chains. By 45, they will have a DIN 45 over here. So that's the way we evaluate for hematogones on the lymphoma patients. For the plasma cell myeloma patients, we caught the hematogones when they were 19 positive, 38 positive, and no expression of light chains over here. So that's by the method of the plasma cell myeloma or plasma cell tube or plasma cell assay. When they have the second method, we also caught them by CD10 expression. And their percentages were very similar by both methods. Here's just some bone marrow aspirate pictures from some of the patients that had a lot of hematogones on their aspirates. And as you can see here, there are some very large cells with kind of immature chromatin. This is probably an early hematogone. This is probably late hematogone. There is some nuclear red cells on the background. There's another picture of a patient with high percentage of hematogones. Here probably some immature stage 1 hematogones, and as they mature, they become smaller and more with more mature characteristics. And there is some granulocyte precursors in the background. Here again, we have the whole spectrum of hematogone maturation. Some larger ones over here. This is probably an hematogone, early hematogone. These are probably late hematogones. And then we have some granulocytes and nuclear red cells on the background. So what do we do with all the flow studies that we analyzed? We ended up with 130 patients. 73 had DLBCL, and 57 had plasma cell myeloma. One of the 73 patients with DLBCL underwent a second autotransplant, and 6 of the 73 patients with DLBCL underwent an allogeneic transplant. On the other side, of the 57 patients with plasma cell myeloma, 6 underwent a second autotransplant. 6 underwent a second autotransplant, and 2 underwent an allogeneic transplant. Each patient had between 1 to 13 post-transplant studies, flow cytometry studies, ranging from 21 days to 15 days post-transplant. Also, data from flow cytometry studies following that second transplant was included as part of this study. So let's look at the patients with DLBCL and their hematogone percentage. In this graph, you can see in the y-axis the hematogone percentage, and in the x-axis you can see the days post-transplant. And as you can see here, hematogone percentage kind of peaks early in the transplant for diffuse large B-cell lymphoma patients. Farther along after the transplant, hematogones are not prominent. Here's the plasma cell myeloma patients. Again, y-axis is the hematogone percentage. X-axis is the day post-transplant, and again, hematogones kind of peak at the beginning, within 1 year of the transplant or so. And I have to tell you that based on these graphs, we set our cutoff for increased hematogones as 5%. So patients with 5% or more hematogones would be considered, was our definition for increased hematogones. So what do we found based on that 5% cutoff? Basically, the majority of patients, 80% of them, had less than 5% hematogones post-transplant, irrespective of the post-transplant day. 24 of 37, that's 65%, of flow cytometry studies with more than 5% hematogones occur within the first year of autologous stem cell transplant. Of the remaining 13 flow cytometry studies with more greater than or equal to 5% hematogones, 6 were after second transplant. We did not find any significant correlation between hematogone percentage and any post-transplant day. We also did not find any significant association with patients with greater than or equal to 5% hematogones at any time with age of diagnosis, age of the transplant, gender, underlying diagnosis, or even pre-transplant hematogone percentage. So then we did additional analysis, and we took the hematogone percentages in 3 specific times here, and this is including all the patients, the plasma cell myeloma patients and the diffuse large B-cell lymphoma patients. And the times were 1 month, 100 days, and 6 months. And then based on percentiles, we set up a definition of increased hematogones for each point. And that definition will be 75 percentile or more. So for example, at 100 days, the definition for increased hematogones will be hematogone percentage of more than 3, based on that 75th percentile. Then with this analysis, we found that there was significant associations between increased hematogones at 1 month and 100 days with a significant p-value. There was an significant association between increased hematogones and 100 days and the 6 months with a significant p-value. And there was a significant borderline association between increased hematogones at 1 month and 6 months with a barely significant p-value. So that means that the hematogones were kind of increasing at the beginning of the transplant, but then they kind of went down after that. So when we restricted the analysis, this is again including all the patients, DLBCL patients and plasma cell myeloma patients. When we restricted the analysis to cases within a year of first transplant, excluding patients that underwent a second transplant during that year, we found that there was a positive association between hematogone percentage and day post-transplant. So again, kind of confirming that hematogones peak or increase during at the beginning of the transplant. Then when we restricted the analysis again after a year of transplant, excluding patients that underwent a second transplant also, we saw a negative association, a statistically significant negative association between hematogone percentage and post-transplant day, as you can see here. And this is after the first year of transplant. Again, kind of confirming that hematogones kind of peak early in the first year of transplant. So here, just showing you the distribution between the two sets of patients with the hematogone percentage. And as you can see, for the plasma cell myeloma patients, there's a wider range of hematogone percentage. The median here, which is the black line, was higher when compared to the lymphoma. And there was a significant difference in the distribution of these between the two patients. So now let's explore if our hematogones are really the heroes or villains. As if you can remember, I said before in some studies, hematogones have been shown to be associated with better overall survival in different studies. So let's see how that pans out for our study. So we did survival analysis, and we had 82% of our patients had a follow-up. And of course, this is expected. The plasma cell myeloma patients had a better overall survival than the patients with DLBCL. That's the nature of the disease. DLBCL patients do worse. But we did found that in patients with plasma cell myeloma that had greater than or equal than 5% hematogones at any post-transplant study, they had a worse overall survival with a significant p-value. They also had a borderline significantly worse progression-free survival. Now, this analysis of survival is in the plasma cell myeloma patients, and is based on the definition of more than 5% hematogones. And this is excluding patients that underwent a second transplant with this analysis. And we can see here that patients that had greater than or equal to 5% hematogone, which is the green line, had a worse overall survival than patients that had less than 5% hematogones. Was the same for progression-free survival. Patients with greater than or equal to 5% hematogones had a worse overall survival, here's the green line, compared to the patients that had less than 5% hematogones, and that's the blue line, and that was statistically significant with a significant p-value. Now, when we remember that we had a different definition for increased hematogones based on the 75th percentile, and for 100 days, the 75th percentile definition for increased hematogones is having greater than or equal to 3% hematogones. And when we did that analysis at 100 days, we saw that patients that had greater than or equal to 3% hematogones had a worse overall survival. Here's the green line compared to patients that had less than 3% hematogones with a significant p-value. Same when we did the analysis at 1 month based on that definition of 75th percentile, we saw that patients that had, for 1 month, the definition or with the 75th percentile is having greater than or equal to 1% hematogones, and we saw that they have a worse overall survival, the patients that had greater than or equal to with a significant p-value, and this is progression-free survival. So, what do we find in our study? We saw that plasma cell myeloma patients with increased hematogones post-transplant had a worse overall survival and a worse progression-free survival. This is in contrast to the other studies that I show you that patients, and they were all allogeneic stem cell transplant. They had higher, the patients with higher hematogones had better survival in those studies. We did not find any association between increased hematogones post-transplant and overall survival in the DLBCL patients. It was just for the myeloma patients. So why these patients had a worse overall survival? So one theory you might think about is that these neoplastic plasma cells may regress and kind of overlap with the hematogone immunophenotype, and they're really disease cells instead of being hematogones. We also conclude that hematogone percentage peaked at approximately 1 year after transplant and then declined. We also can say that post-transplant date is not a robust predictor of hematogone percentage. And so we also set a definition of what extreme hematogones percentage is. And we said that having greater than or equal to 10% hematogones, that's the definition for extreme hematogones. It was quite rare in our study. Only 4 cases had extreme hematogone percentage. So these are the extreme hematogone patients. I'm just going to go over them quick. The first one was a female. She underwent autologous stem cell transplant at age 45 for DLBCL, and she had 13% hematogones following allogeneic transplant. The patient was still alive the last time we checked. Second patient with extreme hematogone percentage was a male, underwent autologous stem cell transplant at age 48 for plasma cell myeloma. He got complete remission after transplant. We found 12% hematogones in a sample 100 days after transplant. He died shortly a year after the transplant. Third patient with extreme hematogone percentage is female. She underwent autologous stem cell transplant at age 65 for plasma cell myeloma. We saw 31% hematogones in a study 6 months after the second autologous stem cell transplant, and the patient was still alive. Last case with extreme hematogone percentage is a female who underwent autologous stem cell transplant at age 48 for plasma cell myeloma. She had 15% hematogones at 6 months after transplant, and this patient is still alive. So, in our study, are hematogones the heroes or the villains? I think based on our study, we saw that the hematogones had a worse overall survival in patients with plasma cell myeloma. So I think we can consider them to be our villains in our study. So future plans, maybe do a prospective study. We all know what retrospective studies are. Maybe include more neoplastic processes, look at that AML, ALL, MDS. The definition of increased hematogones, it's variable through literature, so maybe we should standardize that and do analysis based on that. Maybe that might change some of the results, but that's something to consider in the future. So this article was published it was presented at USCAP, then accepted last summer, and now it was just published last week on the issue of leukemia and lymphoma. So if you want all the details about the study, that's the reference over there. So major points for my talk. So hopefully, at least for our trainees, our residents, fellows, maybe you now know what our hematogones are. Now you know the characteristic immunophenotype. Probably you can pick them up in the flow lab. Hopefully you understand that there is an overlap with the morphology between hematogones and lymphoblasts. We saw in our study that there was worse survival in plasma cell myeloma patients who underwent autologous stem cell transplant. We also saw that hematogones peaked at approximately 1 year after transplant and then kind of declined. We also saw in our study that extreme hematogone values are rare. And so the objectives, like hopefully we fulfill all the objectives for the talk. We describe again the basic biological characteristics and immunophenotype of hematogones. We discuss their associations with prognosis in previous studies, and we discuss our study of hematogones in the setting or in autologous stem cell transplant. I want to thank Dr. Corbell for the opportunity to be part of the study, Dr. McKenna, and then some of the hem-onc docs, Dr. Lazara and Dr. McClune. So these are my reference, and this is for the hopefully warmer days to come. And I will take any questions. Yes, Dr. Linden.
So, it's a great study. I had a question about peripheral stem cell collection. They're reflected over a long period of time. Did you look at types of mobilization? I know Dave McKenna can probably comment more about this, but I'm sure it's very heterogeneous. So in a lot of myeloma patients, if they're difficult to mobilize stem cells, they get pluripotent, and that's probably a newer thing. And since you're really looking at kind of immune reconstitution, in a sense, I think if you went back and looked at all the different ways in which the patients were mobilized, there may or may not be an association. It could be something interesting to look at.
Yeah, we did not look at that, the mobilization, the different types of mobilization, yeah. So I don't know the answer to that. Yes, Dr. Kribich?
Very nice study. Illustrations. Some patients are receiving medication after autotransplant maintenance, either lenalidomide or bortezomib or sometimes combination. Do you have any data on how that correlated with numbers of hematogones?
We did not look at the medications after transplant. That's a great point. Yep. Dr. Carson?
Victor, I'd like to clarify in my mind, see if I understand hematogones. As I understood from your talk, hematogones early on may have small amounts of light chain, but they aren't clonal, and then later on they get heavy chain, and then they become B cells at that point. Is that correct?
Right. Yeah, they spread the polytypic, right?
Right.
B cells. Yep. Yes.
Thank you very much. Very nice talk. So I have one question. You could remind me, or if I miss it, because have you studied the baseline hematogone percentage before transplantation and compare it with after post-transplantation different time points? And if you stratify it by the different baseline and how the percentage hematogones change after transplantation, will that influence the survival rate?
We did look at the hematogone percentage previous to the transplant, one study previous to the transplant, and there was no associations with that. But we just look at that point before the transplant. I don't know if that answered your question. there was no significant association with not in that particular pre-transplant study for each of the patients. Yeah.
Or I'll ask another question. Do you have an understanding of why hematogones in some of the early studies had a good prognosis and in your study did not?
Well, these patients were allogeneic. Most of the ones from the studies I presented were allogeneic transplants.
Okay.
So maybe they have some protective effect, with treatment-related things after, like protective against GVHD or something like that. So that might be an hypothesis. Ours were autologous, so that might be an explanation for it.
Was there an association with age? Because
No, there was-
McKenna's paper showed that in normal people it goes down with age, so in your patient group.
No, there was no significant association with age. Yep.
They were all adults though, so we weren't really looking at children with those issues. I could just point out that each patient, I think it was on average, had 6 post-transplant flow studies, and you saw we had about 100 patients. So Victor looked at and he was pulling in the raw data and redating it, keeping track, and he did an excellent job on just a lot of data, putting that together to get these numbers. They're summarized here, but that represents a lot of work on Victor's part, so it was really excellent.
Don't forget to submit your paper for the rest of the work.
All righty. Thank you so much.